My name is Aisha Diallo, and today I'll be presenting my project on racial and geographic differences in adherence to safe-to-sleep recommendations. Sudden infant death syndrome, defined as the sudden and unexplained death of an infant under 1 year of age. The Safe to Sleep campaign was launched in 1994 as the Back to Sleep campaign. Its original focus was encouraging parents to place infants on their back to sleep. Over time, the campaign expanded to include guidance on creating safe sleep environment, such as using a firm sleeping surface and avoiding loose bedding. The campaign resulted in the reduction of SIDS rates by almost 50% in the US. While awareness of safe to sleep guidelines has increased nationwide, disparities in adherence still exist. These differences suggest that not all populations benefit equally from current education efforts. Based on these persistent disparities, our research question was, does maternal race and geographic settings, specifically urban versus rural residents, affect adherence to safe-to-sleep recommendations? Understanding these differences can help inform more effective and equitable health education strategies aimed at reducing sleep-related infant deaths. Data for this study were drawn from Phase 8 of the Pregnancy Risk Assessment Monitoring System, which includes responses collected between 2016 and 2020. The final sample included over 221,000 mothers across participating U.S. states. PRAMS collect population-based data on maternal experiences before, during, and after pregnancy through surveys administered a few months postpartum. Key variables examined in the study includes maternal race, geographic location, and both safe-to-sleep recommendations and adherence behaviors. Statistical analysis were conducted using SPSS and included descriptive statistics, ANOVA, and t-tests to examine group differences. Before discussing the results, it's important to clarify the difference between safe-to-sleep recommendations and adherence. Recommendations reflect what healthcare providers reported telling parents, such as placing infants on their backs to sleep, ensuring babies sleep alone, using an appropriate sleep surface, placing the crib in the parent's room, and avoiding items in the baby's bed. Adherence, on the other hand, reflects what parents reported actually doing. This includes whether the baby slept alone, slept on their back, slept in their own crib or bassinet, and whether the crib was placed in the parent's room. The distinction is important because receiving information does not always result in behavior change. Overall, average safe-to-sleep recommendation scores were high, with a mean of approximately 4 out of 5 recommendations received. However, statistically significant differences were observed across racial groups. Black mothers reported the second highest rates of receiving safe-to-sleep recommendations. Despite this, they also demonstrated the second lowest adherence to those recommendations. Differences in those recommendation and adherence scores by race were statistically significant with p-values less than 0.001. These findings highlight a notable gap between information delivery and behavior amongst racial groups. When we looked at geographic differences, we saw a clear pattern. Providers in rural areas were more likely to give more complete safe-to-sleep recommendations than providers in urban settings. Additionally, rural parents demonstrated higher adherence to safe-to-sleep recommendations compared to urban parents. This difference was statistically significant. These findings suggest that geographic context may influence both provider communication and parental adherence, potentially reflecting differences in healthcare relationships or community dynamics. Key takeaway from this study is what can be described as a race gap paradox. While many parents, particularly Black parents, reported receiving safe-to-sleep recommendations, adherence did not always follow. This gap may be influenced by factors such as cultural norms, generational caregiving practices, medical distrust, and lived experiences that affect how health messages are received and applied. The higher adherence observed in rural settings may reflect stronger provider-patient trust or more consistent messaging within smaller communities. Overall, these findings suggest that recommendations matter, but simply telling parents isn't enough. Adherence is complex and influenced by culture, social trust, and lived realities. To that extent, we need to make sure our education is culturally appropriate and we use plain language. Thank you. See you at the conference.